Hi everyone.
Once again, welcome you all to my video on ENM guidelines. ENM is the first topic in CPT book, and in this topic, we will be mainly learning about how to code a patient's visit based upon where the patient and the doctor are meeting. So this is mainly to describe the place of service where the treatment was provided to the patient. So in our CPT book, we can specifically see some ENM service guidelines topic. Under that, you can go down and check this ENM guidelines overview. So under that, in the second paragraph, you can see the different categories of ENM chapters or the ENM subheading, and ENM codes will be only from 99202 to 99499. All the other 9 series codes belong to which chapter? So most of us will be knowing 9 series codes belong to two topics in the CPT book. One is ENM, and what is the other topic? So if you know the answer, you can comment it. Okay, so now under ENM chapter, what are the subcategories we are going to see? It's about office or other outpatient services. That means the patient and the doctor are meeting in an outpatient clinic. Then hospital inpatient and observation care services. So this is like patient is getting admitted in the hospital or being observed for less than a single day. That is observation care services. Then consultations. Consultations means a patient is being referred from one doctor to another. Then we will be seeing about emergency department services. Under that, we will be learning about critical care, pediatric intensive care, all those things. Then nursing facility services, then home or residence services. And in addition to all these, sometimes if the doctor is spending long time with the patient, we will be using the prolonged services codes. So these are the subheadings that will come under the ENM chapter. So under the ENM chapter, what basically we should know, how we are going to learn this ENM chapter, and what are the things you will note down when you are going to code an ENM chapter code. So now under this, you can see whenever a patient is coming to the hospital, first thing you have to find out whether the patient is a new patient or an established patient. So how will you differentiate a new and established patient? New patient is a patient who has not come to the hospital for any treatment within the period of 3 years to the same specialty or subspecialty doctors. Then only he will be considered a new patient. Then who is an established patient? Within the past 3 years, patient has visited the same hospital to the same specialty or to the same subspecialty. Then he will be considered as an established patient. For example, I'll give you some scenarios now. New patient. I'm getting a patient today in the cardiology department. For the past 3 years, this patient has never visited the cardiology department of the hospital which I am working in. But he has visited neurology last year. Before that, he has visited a nephrology doctor. So they are all different subspecialties, but he has never visited the cardiology department. This is the first time. So he will be considered as a new patient to the cardiology department. So that is how we differentiate. For an example, I will give you one example for the established patient. Last year, one patient came to the cardiology department, and again he is coming to the cardiology department this year also. Then he will be considered as an established patient. And here they use a term, doctors who belong to the same group practice. Group practice means within a same hospital, who are all working as a group of doctors. So you have to check whether the patient has visited the hospital within 3 years. And again, you have to differentiate whether he has visited the same specialty or subspecialty doctors. Based on that, you can find whether the patient is new or established. So that is about new and established patient. Next, we'll move down. In your book, you can see a decision tree for the new or established patient. You can refer that. So with the help of that, you can differentiate a new and established patient. So this will be mainly used for some services like outpatient services. And for some services, we never consider whether the patient is new or established. Only for certain services we use it, and one among them is outpatient service. Next is, you can see that just about this decision tree, you can see that initial and subsequent services. Initial and subsequent services codes will be used for inpatient or observation care services. Only for that we will be using this initial and subsequent, and how it is differentiated. Initial means that is the first time the doctor and the patient are meeting after getting admitted in the hospital. Subsequent, it may be the second or the third visit. on the following days. For example, if a patient is getting admitted in the hospital today if the doctor and the patient are meeting, it will be considered as an initial service. Tomorrow, if the doctor is coming again and checking the patient, that will become a subsequent service. And in all these services, the time that is calculated will be said as total time. What is this total time? For example, when we get admitted in the hospital, we would have noticed that the treating doctor will visit the patient multiple times. It can be once in the morning, it can be once in the evening, it can be depending upon the patient's condition. So doctor and the patient will be meeting many times in a single day. But what we have to do, what the coders have to do is, you have to calculate the time that was spent by the doctor in the different visits, like for in the morning, afternoon, and in the evening. For example, I say that I visited my patient in the morning for 5 minutes, in the afternoon for 3 minutes, in the evening for again 5 minutes. So how the coder has to calculate this? Coder has to add all these 3 times, like 5 plus 3 plus 5. That is equal to 13 minutes. So based on that, we have to give the code. So that is this initial and subsequent services. You have to calculate the total time that is spent by the doctor on the date of service. And also we will be finding out what is the level of MDM. We will see about the MDM later. Next is, this is again about the split or shared visits. That means a doctor can visit the patient multiple times, but whenever in the code description they say that the total time has to be coded, means you have to add the timings together and report it as a single code. Next point is multiple E&M services on the same date. Sometimes a patient might be undergoing 2 different E&M services on the same day. For example, I say that my patient first visited the emergency room, but his condition was not that severe. So the doctor admitted my patient as an inpatient. He doesn't need any critical care. He was admitted in the inpatient ward. So in this scenario, the doctor and the patient has met in 2 different places. One is emergency room and the other one is inpatient ward. So how are you going to code this? For the first service, you have to report an emergency room code, and along with that, you have to use modifier 25. Then after that, you have to report inpatient service code also, but without modifier 25. So why we have given this modifier 25 to the first emergency room service? Because on the same day, 2 separate and significant E&M services are given, means we have to use modifier 25. And always for the first service, we will use modifier 25. For the second service, we don't need. So whenever you are reporting 2 E&M codes or 1 E&M code, 1 CPT code, along with 1 E&M code, we have to report modifier 25. Modifier 25 will be used for separate and significant E&M service on the same date of service. So this is about multiple services on the single day. And whenever a patient is getting admitted in the hospital, we have to report inpatient services, and under that we have to check whether it is initial or subsequent. And on the last date or the date of discharge, we have to report the discharge services code. So that is mentioned in this discharge services. Next is, along with the E&M codes, sometimes we have to report some CPT, diagnostic procedure codes. For example, my patient came with a fracture to the hospital. I did some examination, and after that I ordered him to go for an X-ray. He took the X-ray, and after looking into the X-ray, I had just found out that there was a fracture. So I will be giving a report on that also. So in addition to this E&M service, for the interpretation and report of that X-ray, I will be reporting a 7 series code from the radiology chapter, and along with it, I will be using modifier 26. So what for this modifier 26? Modifier 26 will be used for interpretation and report by a professional or a doctor. So this is mainly used for the professional service of the doctor, and for the reporting and also the interpretation of the X-ray, I'm using this modifier 26 with the radiology chapter code. So that is how we will be reporting separate services. And whenever a patient is coming to the hospital, first the doctor will ask for the problem, what is the problem and how long it is there, and then he will do a physical examination, and all these will be recorded in the patient's electronic health record portal or questionnaire. Everything will be recorded in the patient's electronic health record. And the E&M services are mainly classified based on the level of MDM and also the total time that is spent by the doctor on the date of service. So now we should learn about what is MDM. What is MDM? So I'll tell you what is this MDM. MDM means medical decision making. Medical decision making. That means what is the problem the patient is having? Based upon the problem, what is the treatment that is given? And all these things will let us decide how critical or serious is the patient's condition. And based upon that, we have 4 types of MDM, medical decision making. So what are they? They are straightforward MDM, low MDM, moderate and high MDM. So these are the 4 types of MDM: straightforward, low, moderate and high. If I say straightforward, the problem will be very minimal. If I say low, the problem is little bit, and moderate, the problem is little severe, and high means it's very severe. It needs immediate attention. So these are the 4 levels of MDM which will help us to report with different codes. And this MDM concept will not work with 99211 and 99281. 99211 is a code for outpatient service under established patient if the service is provided by a qualified healthcare professional but not a physician. 99281 is a code which is coming under the emergency services, and under that also they say that there is no physician, then we will be considering it as 99281. So with these 2 codes, we will never consider the level of MDM. So now, what are the things that will help you to find the MDM? So how we are going to decide with the level of MDM? There are 3 elements. What are they? The first element is number and complexity of problems that are addressed during the encounter. And the second one is the amount or complexity of data to be reviewed and analyzed. The amount of complexity of data to be reviewed and analyzed. And the third one is risk of complications or morbidity or mortality of patient management. So all these 3 things will help you to find out the level of MDM. I'll explain them one by one with the help of a table that is seen below this MDM chapter. You can see here, there is a table in your book, levels of medical decision making, MDM, elements of medical decision making. And in this table, you can find all the 4 levels of MDM and also the 3 elements which will help you to find the level of MDM. And note down, whenever we are reporting the MDM, it can be based on 2 out of the 3 elements. So in a row, if 2 elements are satisfied, you can choose that as your MDM. In a single row, for example, under straightforward, in the same row, I get the first and second point corrected, but this one is not matching. Then I can report it as a straightforward MDM. So you have to always choose the MDM based on 2 out of 3 elements. If all the 3 elements are satisfying, then it's well and good. But if not, if only 2 elements are satisfying, one is not falling under the line, it is okay. You can choose the level of MDM as whatever it is under that line. So now with the help of this table, we will learn more about the MDM. So in straightforward, what are the number and complexity of problems addressed at the encounter? If patient has got one self-limited or minor problem, it can be considered as a straightforward MDM. In a self-limited or minor problem, the amount and complexity of data reviewed, analyzed will be nothing actually. They will be minimal or nothing. Then you can again consider it as straightforward. And for this self-limited problem, the risk of morbidity also will be very less. So what is a self-limited problem? Self-limited problem means the problem which will resolve or heal on its own without any further treatment. It doesn't need any further treatment. For example, patient has got a small cut in the finger. There was a little bit of bleeding, but after that it is fine. The bleeding has stopped. There's no sign of infection and all. It is just a small cut when she was cutting a vegetable, something like that. It is considered as a self-limited or minor problem. It doesn't require any further evaluation or further treatment. In such a case, the level of MDM will be straightforward. And if you want to know the meanings of this self-limited and minor problem, just go down below the table. You can see what is the meaning of problem, what is the meaning of problem addressed, what is the meaning of minimal problem, what is the meaning of self-limited or minor problem. So I'll just read the self-limited problem. A problem that runs a definite and a prescribed course, is transient in nature and is not likely to permanently alter the health status of patient. That is what is self-limited or minor problem. So it doesn't need any further treatment. So that is the meaning of it. So for such a problem, the MDM is straightforward. So next, what is low MDM? In low MDM, the patient might be presenting to the hospital with 2 or more self-limited or minor problems, 1 stable chronic illness, or 1 acute uncomplicated illness or injury, or 1 stable acute illness, or 1 acute uncomplicated illness or injury requiring hospital inpatient or observation level of care. So now under this, you can see that the problem is getting little serious than the straightforward MD. Patient can be having 2 or more self-limited or minor problems, or it should be a 1 stable chronic illness. So what is a stable chronic illness? Stable means the disease is not getting worsened. The disease is not getting worsened. It is a simple disease. It is maintained with the help of medicine, but it is a chronic illness. That means it is there for a long time. For example, if a patient is coming to the hospital with diabetes for the past 5 years, but she is under good control, there is no worsening of the disease or there is no exacerbation of the disease. The disease is under good control with medicine and she is not having any other issue. She is perfectly all right. Then such a condition is 1 stable chronic illness. Then what is 1 acute uncomplicated illness or injury? Acute is just opposite to chronic. Acute means it has appeared suddenly. The problem has appeared suddenly. And it should be uncomplicated illness or injury. That means there is no involvement of internal organs. It is just a superficial injury or illness which has started suddenly and it doesn't have any internal problem. Then it is considered as a low level of MDM. Or it should be 1 stable acute illness. Means there is some disease, within a short term it has developed and it is stable, it's not getting worsened. For example, my patient is having fever for the past 3 days, but no other symptoms. He's perfectly all right. So the disease is not getting worsened. It is under control. It started suddenly and it is there for a short time. Then again, I can consider the level of MDM as low. And if the problem is acute, uncomplicated illness or injury, but requiring hospital inpatient or observation, there is an injury and illness, but that needs some attention. I have to admit the patient or I have to at least observe the patient for some time. Then the level of MDM should be low. And under low level of MDM, what are the amount and complexity of data to be reviewed and analyzed? There are 2 categories. First, we will check the category 2. Category 2 says that assessment requiring an independent historian. That means there is someone along with the patient who is telling about the patient's condition. For example, it can be the mother of a child. Child is the patient. Child is not in a state to explain his problems. So her or his mother is explaining about the patient's condition. In such a case, you can take it as a low level of MD. And also, under the category 1, you can see that tests and documents, and there are 3 points there. And out of the 3 points, at least 2 points should be there to satisfy this level of MDM. So what are these points? First, we will see the 3rd point. If doctor is ordering an unique test, that means doctor is doing some lab test to confirm something. And also he is reviewing the result of each unique test. He is going through that and he is giving the review on it. Then you can consider the level of MDM as low. Or if he is reviewing prior external notes from each unique source, that says that patient has got some old reports, doctor is going through that and that was not done in the same hospital. It is from some other source, maybe from some outside hospital. Then you can consider the level of MDM as low. So all these things will help you to find out the level of MDM as low. And for such a condition, 1 stable chronic illness, 1 acute uncomplicated illness or injury, if we don't do any treatment, there is a small risk. So there is a low risk of morbidity from additional diagnostic testing or treatment. So if this problem is not treated, patient might land up in a small risk which can lead to morbidity. Morbidity means there is something like which is going to cause a permanent damage. There is like loss of some body part. Something is expected if we don't treat that problem. So that is low risk of morbidity. Now we'll move to the third level of MDM, that is moderate. Under moderate, again you can see that the disease is getting little more critical or serious than the low level of MDM. Here, patient will be having one or more chronic illnesses with exacerbation, progression or side effects of treatment. One or more chronic illness, that means patient is having 2, 3, 4, any number of chronic illness. Chronic means which is there for a long time, but patient is having exacerbation or progression. That means the disease has suddenly worsened. It is not under good control. The disease is not under good control. There is a lack of control even with medicine, or due to the medicine the patient is taking for a long time for this disease, now he has developed some side effect. Then it is considered as moderate level of MDM. Or the patient should have 2 or more stable chronic illnesses. Stable, but it is chronic and the number is 2 or more. Then it is moderate MDM. Or patient has got one undiagnosed new problem with uncertain prognosis. That means still now patient has not undergone any testing for a new problem which has arisen within a short time. For example, I say that a patient is coming to the hospital with a big mass in the abdomen. There is a big mass in the abdomen. Mass means there is some growth. I don't know what that mass will be. It can be a tumor, and that tumor can be sometimes a cancerous tumor or a non-cancerous tumor. So that is uncertain prognosis. I don't know how this disease is going to be, what this disease is. Then I can consider the level of MDM as moderate. Or if patient is having one acute illness with systemic symptoms. For example, patient is having fever, cold, cough for the past 2-3 days, and now he is having some difficulty in breathing. That means it has affected the respiratory system fully. So if it has affected the lungs, then only patient will be having some systemic symptoms. Difficulty in breathing is result of the disease that is affecting the lung. So such a case, it is considered as moderate level of MDM. And if it is one acute complicated injury, there is some injury and there is some complication also. If we don't treat it, the patient might land up with some big issue. So such a kind of problem is again considered as moderate level of MDM. And under moderate level of MDM, what are the amount and complexity of data to be reviewed and analyzed? Here you can see 3 categories. The first category will include all the 3 points that were said in the limited, like review of prior external notes, review of result of each unique test and ordering of each unique test. And in addition to that, if assessment requires an independent historian, and out of these 4 points, if any 3 is satisfied, then you can consider it as moderate. Then what will be the next category? Independent interpretation of test. That means patient has got some test that was done by a different doctor, but the new doctor who is taking the patient is giving the report on it. He is giving the interpretation and report, but the testing was done by a different doctor. Then you can consider it as a moderate amount of complexity of data to be reviewed and analyzed. And the third category is discussion of management or test interpretation. That means here the doctor is discussing about the patient's treatment or the testing with some other doctor, external physician. Then it can be considered as a moderate category of data to be analyzed. Then again it will fall under moderate level of MDM. And under moderate level of MDM, you can see some examples that is given under the risk column. So for such a problem, there is always a moderate risk of morbidity from additional diagnostic and treatment. So under this, what are the examples they have given? If patient is managed with prescription drug, you can take it as a moderate problem. Or patient needs a minor surgery, but the surgery is having some identified patient or procedure risk factors. That means there is some issues with the patient. For example, patient's diabetes is not under control, I cannot do the surgery immediately. Or there is some individual factors, like if someone is having some smoking or something like that, smoking habit, alcohol, like that, we cannot do some treatments. So that will affect the treatment. So that and all will fall under moderate category. Decision regarding elective major surgery without identified patient or procedure risk factors. Patient needs a major surgery, but it is elective. Elective means we can do it anytime, but not emergency. Maybe after 1 week or 2 weeks we can do it. We can take time and do it. It's not an emergency surgery. But here there is no identified patient risk factors. Next is diagnosis or treatment significantly limited by social determinants of health. We cannot do some treatment or testing because of patient social determinants. For example, due to the economic status of the patient or due to the habits like alcohol. Patient is under alcohol effect. We cannot do some testing and treatment. So all these can affect our treatment. In such a case, the risk is considered moderate, and again it falls under moderate level of MDM. So now the last level of MDM is high. So high level of MDM means the disease is more severe. It has to be treated intensively. It needs some intensive treatment, or a critical illness is there. That and all will be considered as high level of MDM. So under high level of MDM, what is the number and complexity of diseases that is addressed at the encounter? One or more chronic illness, same like moderate, but a small difference is there. It says that it is with severe exacerbation, progression, or side effects of the treatment. So there is some severe exacerbation, means suddenly, and it has like worsened very badly. So it is a severe exacerbation or progression or side effects of the treatment. It is considered as high level of MDM. One acute or chronic illness or injury that poses a threat to life or bodily function. For example, patient met with an accident. Due to the accident, he has got a cut off hand, like the hand has been cut off, but it is like having little attachment. There is severe bleeding from that part of the body. If he is not getting treated, what will happen? So he might lose that hand, or due to the excessive bleeding itself, he might die. So in such a case, the level of MDM will be high. The level of MDM will be high. And in the amount and complexity of data to be reviewed, there are again 3 categories, same like the moderate level of MDM, same thing will be repeated. So if any of these 2 categories are there, it is considered as high level of MDM. So at least 2 out of 3 categories is needed to be chosen as the high level of MDM. But in moderate, they say that at least 1 out of 3 categories will be considered as moderate. But here it is 2. Out of 3 categories, at least 2 should be there. There should be 1. Next is, if such a kind of problem is not treated, there is a high risk of morbidity. And under that, what are the examples they have given? If patient needs some drug therapy, which is requiring intensive monitoring for toxicity, patient is getting treated with some medicine, but sometimes that medicine can lead to some toxicity. Toxicity means nothing but poisoning like effects. So we have to intensively monitor that patient. So there is a medicine which can cause toxicity, but that is the treatment we are giving. But we have to closely observe and monitor the patient. Then it can be considered as a high MDM. Then decision regarding elective major surgery, but there is identified patient or procedure risk factors. And the next point is decision regarding emergency major surgery. And next one is decision regarding hospitalization or escalation of hospital level care. That means patient has to be immediately admitted in the hospital, or the care should be escalated. Escalated means it should be increased. For example, patient is just admitted as an inpatient, but later, due to the severity of the disease, either the patient has to be shifted to an ICU or a critical care unit. Then again, the level of MDM will be considered as high. Then the next point is decision not to resuscitate or to de-escalate care because of poor prognosis. That means here they are not going to further escalate the care. They are not going to give more treatment, or they are going to reduce the treatment, de-escalate the care because of poor prognosis. That means even with this treatment, there is a chance of less survival for the patient. Patient will not survive even with a high care. So we are going to either reduce the care or we are not going up for higher level of care. That is all considered as high level of MDM. And decision regarding parenteral controlled substance. That means the doctor is going to give some medicine through injection, through IV route or IM route or IA intraarterial, but it is with a controlled substance. That means they should get permission before giving that medicine to the patient from the medical department of the country. So in such a case, it is considered as high level of MDM. And below this MDM table, you can see all the words that are given in the table with their meanings. So you can read that and understand that. You will get a better understanding about this MDM. And one more thing, in AAPC website, they have a tool which is called as MDM calculator. MDM calculator. It is available in the AAPC website itself. It is said to be ENM calculator or MDM calculator. In the CPC exam also, you will get this ENM calculator on the right hand side of the exam screen. So whenever you are not able to find out the level of MDM, what you have to do is you can use this ENM calculator to find out the level of MDM. So how we are going to do it? I will just give you one example. Just imagine that a patient is coming to the hospital today with a swelling in the hand after he met with an accident. So he is coming to the hospital, doctor is examining him and he is giving the treatment and he is actually a new patient. So first thing what we have to do is when you just open this codified by AAPC, this MDM calculator, first thing what you have to enter is the date of service. We will just take it as today. So I'm just putting the same date. I have to save it. Then it will move to the next column, that is to describe about the service that was given to the patient. I will just make it as an office or outpatient service and the type of visit as new patient. So now on this day there was an outpatient and he is a new patient. That means within the past 3 years this patient has never visited the same hospital to the same specialty or subspecialty. So now I will just save this. Then this will move to the next point, that is medical decision making. So for this patient, doctor will first do the examination and find out what all problems he is having. So for this particular patient, there is just a swelling in the hand and pain, nothing else. No other health issues. He is just a 20-year-old male with no other complications, nothing like that. So here I'm going to put this under one acute uncomplicated illness or injury. One acute uncomplicated illness or injury, because I see that patient is not having much pain. It is just a slight pain and I'm not finding any internal issues like a fracture, nothing like that. There is some muscle sprain. So it is a minimal problem with uncomplicated illness or injury. So I'm just putting it under one acute uncomplicated illness or injury. And also the amount and complexity of data to be reviewed and analyzed. As based on this examination, I'm not finding anything abnormal here. So I'm not doing any testing and I'm not going through any prior notes also. Patient doesn't need any x-ray or anything like that. So I'm not doing anything. So there is no review of data, review of results from each unique test and ordering of each unique test. I'm not entering anything. But if I have to enter, I have to enter it based on the number of testing that is done by the doctor. I'm reviewing the test, how many tests the doctor reviewed. Based on that, I have to give the number 1, 2 like that. So now I'm not entering anything. So now we'll move to, for each category of reviewed and analyzed data identified, select the checkbox. Here you have 4 things. We will read what they are. First one is minimal or none. Second one is assessment requiring an independent historian. Here this male, 20-year-old male, he came on his own. There was no one with him. So I don't have to choose this. I didn't do any interpretation of the test performed by another physician, and also I didn't discuss any management or test interpretation with external physician. So I can just pick this as minimal or none. Minimal or none, because I did nothing. So it is considered as minimal or none. I have chosen it. Now I have to go down to the risk of complications and morbidity or mortality of patient management. For this patient, I am just going to give an elastic bandage. I'm not doing anything else, and advise the patient to take some rest for 1 day. And if the problem is persisting, I'm requesting him to come for a review, and after that, if he needs, I will send him for a physiotherapy. So now at this moment, I'm not giving any physical therapy, nothing else. I'm just giving a bandage and the rest. So now for this condition, you can see at the end of the MDM table, they will show the level of MDM. So for this minimal problem, the MDM will be straightforward. But in this patient itself, if I change the scenario, I say that my patient has a fracture. My patient has a fracture. The whole picture will change now. I have to alter all the data I have entered here. I have to alter everything. Then the level of MDM will also change. So based on the severity and the criticality of the disease, the level of MDM will change. Now, if I save this, I can find the code, what I have to use for this patient at the end of this. You can see the code is 99202. This is a code for a new patient as an outpatient service, and also the MDM was straightforward. So based on that, I have got the code 99202. So this is based on MDM calculation. And here, the third option, what you are seeing is time-based coding. Time-based coding. What is this time-based coding? Under all the MDM services, you would have seen that they say that the doctor should be spending 10 minutes, 15 minutes, 20 minutes like that. So if in the question or in the case report, they say that the doctor and the patient had a visit for 10 minutes, 15 minutes like that, you can enter that also. For example, I'm entering here that the doctor and the patient met for 10 minutes. So if I submit this again, I will get a code as the same thing, straightforward level of MDM. So based on the time also, we can get a code. Based on time and based on the medical decision making, the final code level will be given to us. It is straightforward and the code is 99202. So this is how we have to use this MDM calculator. In the exam also it is there. You can all try doing this. With any questions like E&M questions are available on Google itself. You can check them with the help of this MDM calculator. If you're not able to find the MDM, then you can use this MDM calculator. This will be very helpful to you. So these are the general guidelines about E&M chapter. Hope this video is helpful to you. If you like this video, please like, comment and subscribe. Thank you.